Hello, welcome. Welcome in the Thorax Center. Can you hear me?
Ik hoor hem niet.
Hello? Hello, can you hear me? Oh, great. Welcome in the Thorax Center. I'm Roberto Diletti. It's my pleasure to be here with my colleague and friends Jeroen Wilskut and my great team. Welcome. Maybe we can start immediately having a look at the case of today, if for you is okay.
Yeah. I don't know if you guys can, thanks for the introduction, Roberto. Yeah, there we see our slides. So maybe we can take a look at the patient demographics. Yeah, so I think we've got an interesting case today of a CTO. The patient is a 50-year-old male who presented not so long ago to our center with a non-STEMI. And he's been known with vascular disease. He's got diabetes, hypertension, hypercholesteremia. Like I said, a non-STEMI a couple of weeks ago, he presented to us. He is already known also with coronary artery disease. CTO of the right has been existent for at least 10 years. TTE was done, normal wall motions and no significant valvular disease. ECG was normal. And the angio of a couple of weeks ago, which we did after the discovery is done of the non-STEMI, you are looking at right now. And as you can see, there is the known CTO of the RCA, which is a dominant vessel. You can see some antegrade flow. There seems to be some recanalization or bridging collaterals. And on the left, you can see a system that has been has some wall irregularities, but no significant disease, and a rather large right that's been filled retrogradely through mainly a epicardial vessel and possibly some septal collaterals. We did extensive diagnostics that time, especially of the LAD. We did an OCT to see if we saw any, smaller plaque ruptures that were not visible angiographically, but there were none. Also, we did an FFR afterwards, and it was a non-significant. I believe it was 89. So we determined that the CTO must have been the culprit of the non-STEMI. Also, this patient has been known with angina for the time that he has the CTO. So we decided that those would be good reasons to treat the CTO, which we're going to do today. Any questions up to now?
No, that's a great case, and I think you described the collaterals well. Perhaps just really quick, Margaret, tell me quick, this seems to scream to me retrograde in a sense, but it's not the straightforward collateral. So what are your thoughts? How do you analyze this if you're just looking at these angiograms? Now, obviously, we've only seen 2 angiograms like this.
So the first thing...
I just have a comment. So we...
Go ahead.
I cannot hear. Yeah. Margaret. Okay. We go a little bit.
No, it's okay. You can go ahead from the live case site. That's all right. And we'll come back to the panel
basically
later.
We had yes. So we try to understand what is the best retrograde collateral to perform the procedure. We had just a little bit of testing of surfing of the septals. We saw that the septals were quite small. There was not a clear connection. We tried a couple of times. Maybe we can have a look. I don't know if you can see my screen. We tried a couple of times to see the to surf the septals. We saw that there was some connection, but was not that big, not that easy. So we try to understand now if we can use the epicardial. The epicardial looks a big vessel, but is very tortuous. So in these cases, you might be triggered to go directly to the epicardial, but it's not something that is really trivial and easy to do, because they can have spasm, and it can be very difficult to cross them because of the tortuosity. So after trying a little bit the septals, we went now to have a look of the epicardial, And we went there with a Sion wire just at the beginning. And now we advanced the microcatheter that is, by the way, a Mamba Flex. I think is one of the first used in epicardial of this new device. I don't know if you have experience with this device. And now we exchange for a Suo wire to try to navigate the distal part. So now where we are there. You see, we are very distal in the epicardial vessel, and we are trying to navigate this very tortuous vessel. At that point, there is a loop of the epicardial, and this is tricky because at the loop there is also a small side branch, and the wires could tend to go in the side branch. So that's the tricky part of the retrograde approach in this moment. So
yeah,
we are
no,
trying to navigate now the epicardial. You see that?
Yep. And while you work, we'll talk a little bit, if that's okay, because there's a little bit of a delay. You know, sometimes the septals can be served blindly. The other thing that can be done sometimes, especially when you have a dominant epicardial collateral like this, is you can actually occlude flow more proximally in that circumflex and actually inhibit the epicardial flow and then take an injection to see if the septals light up more effectively, because these patients' collaterals are somewhat dynamic. Margaret, tell us a little bit about how you assessed the case from the beginning and you know, the question I had asked you earlier.
Yeah, so I would go through all the features Didier and I both discussed in our talk. So just assess all the anatomical characteristics. I agree that it looks here like we've got a dominant epicardial collateral from the LED round to the PD. And often in that situation, you don't have crossable septals coexisting. But I would do exactly as the guys did here. I would explore the septals because it's a safer option, because sometimes you have non-visible connections. The other thing I didn't really see, which I'm sure the guys have looked at, was the location of the distal cap. So if the distal cap here was proximal to the bifurcation, I would think about doing ADR before retrograde for safety reasons. But if the distal cap obviously is at the bifurcation, then I would commit to going around the epicardial. In the situation like this, where you have a one dominant collateral, if that is the case, you have to be very aware of the fact you might make the patient ischemic or can cause hemodynamic compromise. So you always have to have that in the back of your mind. And I agree again with the wire choice. I would take a Sion to get round into the epicardial, then I would switch for the Suo. It's nice and soft and usually takes tortuous epicardials much better than any of the other available wires. And in our centre, I would be using a Caravelle in this situation, one of the low-profile retrograde microcatheters.
Yeah, I would agree that we have tried the Mamba catheters, and they're a little bit bigger. But the Suo is a perfect wire for this. It doesn't really have a lot of body, but you don't want body because of the problem with compromising the collateral. And then the question is, how do you get the microcatheter to follow? So it's great that we have the split screen here, and you can see how, you know, there's gentle twirling. The left hand typically is moving as well, and then he'll advance the microcatheter to give him a little bit more support as well.
So you see, this is quite a tricky position now.
Yeah.
Let's see if you can make the bend. Tasha? Tasha? So we are down, but there, as you see, there is a bifurcation. So that's also the quite important part, because we need to be able to find a good vessel, which is this one. Go. There you go.
Very
there
nice.
You go.
Now back to so tell us now, you know, how are you?
But you can appreciate how tortuous and how moving is the epicardial. So you have to be quite careful when you go in the epicardial vessel like that.
That's right. Now tell us, is there anything special about how you're going to get the microcatheter through the epicardials? Because I would wager that most of the audience has not done this before. Spinning, advancing, back and forth. Tell us.
Yeah, so that is also a tricky part, because you have to take into consideration that you need some support to go down with your wire, but usually you use a Suo wire, which is a very floppy wire. So the tip of the microcatheter, if you push the tip too close to the tip of the wire, you will have basically no support from the wire, and you can damage the epicardial. So you have to have a good balance between support for the wire and the fact that your wire is extremely floppy and your guide and your microcatheter can damage the vessel, the epicardial. So let's try to see if this catheter is crossing the epicardials. This catheter, you need to clockwise. It's not like the Corsair that you need to anti-clockwise. This one you need to clockwise. Also, I had the feeling that the tip was a little bit stiffer than the Corsair, so I will pay an extra attention to the movement of this catheter.
Yeah, this catheter for sure is stiffer than, for instance, the Caravel. So you have to be a little bit cautious with that part of it.
So what's the rationale?
I'll try to be very cautious.
Microcatheter in such a tortuous epicardial.
Sorry, say
yeah,
that
it's
again?
true.
Yeah, so my question was just for the audience, explaining the rationale of using a slightly stiffer microcatheter as compared to the Caravel that is regularly the first choice for such tortuous epicardial vessels. What are the advantages of the Mambaflex microcatheter?
So yeah, well, basically we are trying to understand how is working this device. I think that in this case you have quite a large vessel, so it's not that you really need to navigate a small vessel and try with the Caravel. In this case, it's quite large, and I like to have a little bit more support. As this catheter is probably a little bit stiffer, might give some more support. But of course, this is something that we need to test and to see.
Thank you.
So let's just, what we're going to do is we're going to watch you track this microcatheter through, and then we are going to go to Leipzig to then go back and forth.
So I feel resistance there. So can be that there is some spasm at that point, is just where the loop was. So let's see if we can cross. I will be very gentle, actually, and then let's see. Maybe in the meantime, if you want to go to the other cath lab, we will try to advance very carefully.
Yeah, that sounds fine. We'll go to Leipzig. I would just caution you a little bit with this catheter through that collateral, and obviously it's good to get experience, but sometimes when it's this tortuous, it can be a challenge. So with that, let's go to Leipzig and see what they have in mind, then we'll come back to you and see how your progress has been.
Sure.
So, good afternoon, everyone. I hope you can hear us from Leipzig. So welcome again in the Leipzig Heart Center. We're today in the cath lab. And my name is Mohammed Abdel Wahab. On my left-hand side is Nico Mayunke, who's going to do the case. We have Ulrike and Ines helping us from the cath lab team. I'd like to present the case in a couple of slides. Can you show up the slides, please? So we don't have disclosures. Next slide, please. So this is a 73-year-old gentleman who has angina class 3. He has some typical cardiovascular risk factors, including diabetes, hyperlipidemia, and hypertension. And he already has a known coronary artery disease. So this first started in the year 2007, where he had PCI and implantation of a DES in the mid-LAD. 12 years later, he presented with recurrent angina, so he was more or less symptom-free for 12 years. And last year when we saw him, he had an in-stent restenosis, or maybe it was some sort of a neoatherosclerosis in this old stent that was treated with a DAB, and at that time already we saw that he had a chronic total occlusion of his right coronary artery, which was patent in the year 2007. So it occluded probably somewhere in between, but his symptoms actually started last year. Next slide, please. So after treating his LAD, he didn't become asymptomatic. So there were some non-invasive tests performed showing normal EF, normal left ventricular ejection fraction. He has a slightly reduced GFR. Next slide, please. And then we looked at inducible ischemia using the SPECT imaging examination. You can see here that he has clearly a large inducible inferior wall ischemic burden of 23%. And again, his left ventricular ejection fraction at rest was maintained at 54%. Next slide, please. So this is his angiogram, his recent angiogram. You can see here that in the proximal RCA, there's some intermediate stenosis, and then there's a CTO in the mid-segment. Next slide, please. The LAD stent after treatment with the DEB last year is patent. You can see here there are a couple of septal branches that supply retrograde septal collaterals to both distal branches of the right coronary artery, and you can see that at least visually when you compare both images, that the occlusion is somewhere between segment 2, between the mid-RCA and the bifurcation. Next slide, please. So looking at the scores, we chose here the JCTO score. And you can see here that if you click, please, on the slides. Can you click, please? So this is a rather tapered proximal cap, or a tapered entry into the occlusion segment with no calcification. If you click, please. No bending. Can you click? Yes. Click, please. Next slide. Yes, click. The occlusion length is a little bit ambiguous, so it appears to be visually maybe longer than 20 millimeter, but it could be shorter as well. And this is not a retry lesion. So click, please. Forward, forward. So we have a total of 1, maybe 2 points. Click, please. Yes. So it's more or less of an intermediate to difficult case. Next slide, please. This is the summary of the case, and I'll hand on to Nico, who will tell you about our strategy, how we're going to tackle this case, and meanwhile you can, of course, discuss and ask us questions. Nico, would you want to talk about the setup and what we're planning to do?
Thank you, Mohammed. Hello, everybody. Let's talk about the setup first. We have a sheath, a 7F sheath in the right femoral artery, and a 6 French sheath in the right radial artery. We use a AL1 for the RCA and the EBU 3.5 for the left. We already intubated the left and right coronary artery and already did a dual injection.
Maybe you can go to the angiographic images, please, for a second. And you can see this dual injection. Again, the occlusion, the tapered entry into the occlusion segment, which begins somewhere between segment 2 and segment 3. And again, you see the vessel at the bifurcation. It appears a little bit long, but it could be shorter. So I think, and we may discuss this, our initial approach would be standard antegrade approach, using wire escalation. Yes. We discussed a little bit whether we would, if this failed, if we do a subintimal tracking entry, but we wouldn't prefer to do this because of the localization of the distal cap near the bifurcation. So probably if we fail antegradely, we will rather swiftly switch to a retrograde approach.
Yes.
Yeah.
Totally agree. I already forwarded a microcatheter down to the proximal cap, and I think antegrade wire escalation is a good frontline approach because we have a tapered proximal cap, as you said already. So, as you can see, the microcatheter is already down next to the proximal cap. It is a fine cross, 130 centimeters. And I will now advance Fielder XTA. This is a tapered, soft tip, polymer jacketed wire. And first I will do a small bend at the distal end. I would like to show you. Can you show my fingers or the... So the bend is very short. Only 1 millimeter.
So Nico, as you are shaping your wire, you're obviously using
I think it's a small.
2 guiding catheters with support. So you use an AL1 and an EBU.
Yes.
Can they hear me? Okay, yeah.
Yeah.
But you use a 7 French for the right to engage the right and a 6 French to engage the left coronary system. But would you consider 8 French, or is that abandoned in your practice?
No, this is not abandoned, but I think not necessary in this case. I like the 7 French approach for the CTO vessel to have a good backup. And to have the option to use different systems, whatever, balloons, large balloons, more than 1 microcatheter, but also 8 French is possible, and we do this sometimes, yes.
Yeah, I think for the post-CABG patients where you may need more support, that's where
Nicolas, in your cases?
potential. But I think most things can be done through 7 these days. 8, you can sometimes use a long sheath because that allows you to draw ACTs off the sidearm. But if you have a retrograde, you can also do that way. I do think one point for the audience that should be made, and this is consistent with both this case and the prior cases, you heard both operators talk about the bifurcation distally and how that would modify the strategy and make you favor retrograde and not doing dissection reentry. The whole point of that is because if you do a dissection reentry, you can typically jeopardize one of the branches of the bifurcation. You can sometimes bail out of that by reentering into both branches, but that's the reason why the distal bifurcation is important to consider when determining what your strategy is going to be.
Yeah, that's a good comment.
About the
good comment.
retrograde system. I see you have 6 French for retrogrades, which obviously you can do retrograde 6 French, but it can make your life quite difficult. I would usually use a 7 if I think I'm going to use a retrograde bailout.
Yeah, I think you're totally right. Maybe we're a bit overconfident here that we will manage antigradely, but particularly that we got the task to do an antigrade case. But this, you're totally correct. I think having a 7 French catheter for the retrograde approach would also be has many advantages, of course.
So it looks like you penetrated the proximal cap, and now you're trying to basically do subintimal or intraplaque tracking is the idea.
Yes, yes. I'm looking for microchannels or soft tissue, and I'm drilling the wire, pull it back when it gets stuck, turn it, and try to find microchannel.
So while you work, I'm going to ask the questions to the panel, and then you can jump in if you need to. Didier, some people use biplane or like using biplane, especially in this area of the right corner. Do you use it, or how do you figure out that you're going in the right direction and not along the RV margin?
Unfortunately, I don't have the opportunity to use it because we don't have it in our cath lab, but this is something that is clearly valuable if you want to understand what is the track, the path of your wires and microcatheters. But I have to say that I'm quite liberal when it comes to CTOs, and I don't really oppose integrate and retrograde techniques. I do consider that this is a continuous. It's the same entity. So I always start integrate, and if I see that the wire enters the suboptimal space, it's part of the strategy. I may switch and complete with the retrograde access to connect both the proximal and distal cap. But we have here in Toulouse the rule of maybe 5 to 10 minutes. If you see after 10 minutes that you don't make progress and you are not into the true lumen, we deliberately go suboptimal and connect with the retrograde access. So I don't really like to oppose both techniques. Yes. I do believe that we have to combine both and go from one to the other one regularly. If you have the biplane, it's going to make it easier to see the path of the wire. If you don't have it, think about moving retrograde and trying to understand the path of the vessel through both assets.
Yeah, the radiation can be a little bit higher.
To escalate here.
Yeah. Yeah, I agree. So what's going to be your next choice in terms of escalation? We saw you advance your
next choice is a Gaia.
It's a Gaia second.
Gaia second.
So anyone on the panel opposed to using Gaia at this point? Because Didier, you spoke about getting subintimal and then potentially knuckling, and many have advocated that to be a much safer approach than the Gaia. And we always get into these debates and arguments. So anybody want to jump into that one? What do people think? Go for it, Margaret. I see you smiling.
Choice here. I think it's we're still working on the premise. It's not, the occlusion's not kind of overly lengthy. It looks like the operators can see relatively clearly where they're going, and if they're careful and use feel, then I think it's a reasonable choice. But you're right, Ajay. I think if you're struggling with ambiguity, you should definitely take the safer option and use the subintimal space.
I think we made some.
And one thing is, good progress there.
Progress.
A retrograde injection.
Yeah, the retrograde is the key injection to make. You know, we often, once you start antegrade, you try not to inject antegrade, but at this point, big dissection planes haven't been made. The microcatheter is there, so the risk is a little bit lower at this point with injecting antegrade. But really, the key is to do the retrograde. And you can actually advance the wire as you're injecting retrograde and see exactly where you are. But things look pretty good here.
Okay, so I think we made some good progress, and I will now make a retrograde injection to see where we are. Okay. Not sure.
So that's still the Gaia that's there, yeah?
That's still the Gaia.
Yeah. How does it feel?
So you maybe.
It feels good. Or
maybe you should.
Yeah.
Continue a little bit. Yeah.
I think it's...
So in this situation, if I think I'm across, but I'm not sure, I think a good tactic is to go with your microcatheter and switch for a friendly wire, which will tell you immediately whether you're luminal or not.
Yes, good idea. Good idea.
Let's see how the microcatheter behaves.
Now, you have to be cautious about doing that if you're with a stiff wire, but in this case, the likelihood is that it's in the subintimal space, in which case it's okay. But the de-escalation is important because otherwise that's how you end up in the pericardium or somewhere else.
Correct.
So I
don't mind just going to the
push.
Imaging view. Yeah, that's great. So the AL is a good choice here for support. There was calcium to start off with, and you may need a guide extension of some kind as well to further your support.
Ajay,
that's a good point, Ajay. I think I've started using guide extensions in a lot of my cases in the antegrade system, and I know you guys do in New York as well, because if you do end up subintimal, it'll keep your subintimal space small and reduce your hematoma formation. So I think it's a really good tactic.
Ajay, I don't know about you guys at Columbia, but we've certainly moved away from using fine cross when we do integrate wire escalation. We tend to prefer turnpike or Corsair, especially when you're struggling, the ability to rotate it and get it more distal, we find is quite useful.
Yeah, the spinning aspect, you can kind of spin the fine cross, but not as well. But the spinning aspect is really important. We do use fine crosses for if we're going to do septal injections because the lumen's a little bit bigger. But for these types of cases, we're often using turnpike spiral or something like a Corsair Pro. This is the case where you could try the other microcatheter that's a little bit stiffer. And so it's important. They've shifted views, and they'll hopefully do a retrograde here and see what the challenge with the Gaia, though, is if it's kind of free here, it was more dangerous than perhaps a jacketed wire with a knuckle. But because of the bifurcation location, you have to be cautious about knuckling too far down.
It seems to be a very long segment.
It's very long.
Yeah, it's a very long occlusion.
Very long, yeah.
What are you guys doing just now? What stage are you at?
Is this the Gaia still, or a different
depends
one?
here, like a little bit. Yeah, it's still the Gaia, and I think
still
it's
the Gaia because
depends on your feeling with
yes,
how the wire behaves.
That went somewhere.
Okay, so this
Definitely,
is wrong.
it definitely went somewhere.
As you can see.
Wrong,
Yeah.
It's definitely wrong.
Yeah, but the key is not to follow with the microcatheter, because for the audience, these types of things in a space that you don't know of you have to be watched, but the likelihood of a major issue is low. If you follow with a microcatheter, then you've made a much bigger hole, and that can become a problem.
So Ajay, what do you do now? Do you go parallel or do you go retrograde?
I think given the location of the bifurcation here, the retrograde is probably going to be favored. And this work has to be done at some point anyway. If you're going to go retrograde, you're likely going to be ending up with a reverse cart. So this work is okay. But I think the likelihood at this point of being able to redirect back in without causing hematoma extension and compromising the bifurcation is probably low. Others, Didier, Margaret, Holger, what do you think?
I think it totally makes sense to start to work a little bit on the retrograde side and to see the progress that you make, because it's a good thing that they went suboptimal. If they can navigate retrograde and connect just at the proximal end of the distal RCA, it's going to be a good location from my side.
Okay.
Sure, they can consider to
what do you think? Should we switch to retrograde or?
They can also use a parallel wire technique, so there's maybe an option. So their task is to show it integrately. So maybe we show some more escalation on the next step.
I think you can maneuver it, then probably I would switch to retrograde.
And do you use a dual lumen for that now, or do you still use single lumen, or?
No, it's a single lumen, no?
It's a good question though, because with some of the newer dual lumen catheters like the Sasuke, it has a low profile and it's pretty good, and that might be a way to ensure that you are kind of going, or at least starting parallel. We don't use parallel wire technique very much, but I think if you were going to do it, that would be the way.
Yeah. Let's do a parallel wire for a second before going to retrograde.
Yes.
If you agree.
I've had,
I agree.
Okay.
some quite nice experience with using the dual lumens or even the triple lumen recross to re-enter in this type of situation antegrade before switching. So sometimes it's worth a shot.
Do you want to use a double?
And Margaret, if you're going to do that, what wire would you use? Do you use a penetrating wire or a jacketed wire? Through this side lumen.
So if you've got good visualization of the distal target, and if you track subintimally antegrade and you can still see your distal target clearly with a retrograde injection, then sometimes I've done it with the Gaia 2 or 3, just very focused puncture through, just like you would do with the Stingray.
It's like almost like a
sometimes
Stingray,
it
but
works,
without.
sometimes it doesn't. Yeah, exactly. But your subintimal space needs to be quite tight
I'd be
for it to
interested
work,
to know your
because
primary
otherwise,
wire
obviously,
choice now
the
if you're
lumen will
going
just
to
move
do,
as you
if
try
you're
and
going to
puncture
go parallel.
the subintimal tissue.
Yep.
So I have to say.
All right. So show us. So what do you have planned? You're going to take a second system, and
Now we are withdrawing the
We're taking
fine
out
cross.
the fine cross, and then we'll take the same microcatheter again with another wire.
So you're using the trapping balloon technique to just withdraw the
Yes.
Exactly, yeah.
fine cross.
And for those that don't do CTOs, just learning the trapping balloon technique alone is a great thing, because it allows you to maintain short wires, not lose your distal wire position. Even if you have a long wire, you can lose distal wire position. So it's important to know how to do. And similarly, make sure after you've trapped and withdrawn your catheter that you then bleed everything back so as to get air out of the system. Otherwise, you'll inject air down the corner.
Yeah.
Okay.
Yeah, exactly. It's a very important point. So again, it would be interesting for us to know what you guys would choose as the next wire for the next step for a firewire technique.
Okay.
So personally, I would try a different property wire. Okay. So personally, I would try a hydrophilic coated polymer plastic jacket wire like the Pilot 200 that has
like
enough stiffness
like
and different property, just to try it before using another Gaia 3.
Exactly.
Yeah.
Yeah.
Or Gladys.
Pilot 102.
The other
Yeah.
thing.
Pilot better. We will take a pilot now.
Yeah, without
This
trying
is
not
a
to
very
knuckle it.
interesting case.
Trying not to knuckle.
Something polymer jacketed.
So why don't you do this? Erasmus is ready to take us, so why don't we go back to Erasmus, if you don't mind. Oh, do you have the wire? You have the wire. Why don't you do this? We'll go to Erasmus. Why don't you store the fluoro, if that's okay? Because they're waiting for us,
Yeah,
and
of
then
course.
we'll come back and.
Yeah, sure.
That would be great. Thank you so much. Okay, let's go back to Erasmus.
Yes.
All right, tell us what you've done.
Hello, hi, welcome back. It's a pleasure to have you back. So, what we did, maybe we can have a look. Oops. So basically, can we go back? Can I have back the? So maybe I can do this. Yeah. So what we did, we went in the distal right and then up to the proximal right. You can see the advancement of the microcatheter. Maybe I can show you there. Can you see our screen?
We can.
So if you look there, so I was gently clockwise-ing this microcatheter, and then it popped in. So he advanced in the distal part. That was the point with the loop where probably there was spasm. So from this point on, maybe we can see the next. We advanced there, and we tried a retrograde wire escalation technique, but it was really calcified there. I couldn't advance to the proximal catheter. So we decided to go for proximal dissection and reverse cart. And you can see here how calcified was the lesion. So we advanced in subintimal space. This is dissection. We tried to dilate the dissection, and you see the calcification. Hopefully, in the end, we managed to open it, and then we did this. So we ballooned it so much that we connected the distal dissection and the proximal dissection, and the wire went in even without a classic reverse cart. So that was a quick reverse cart, I must say. And now we are just advancing. We just advanced the microcatheter. Maybe you can see from the live image now. We advanced the microcatheter in the Guidezilla, and we are externalizing with the RG3 wire. Do you have
Roberto,
any question at this point?
Roberto, that's fantastic. Just hold on 1 second so we can explain to the audience basically what happened. So wire went across, then the microcatheter went across, and then tried to advance the wire retrogradely, but couldn't get progress that way. And so when you can't get progress, you have to make a channel and somehow get things moving antegrade. And it's facilitated by the balloon with a guide extension. You then extend where your guide is, and that allows your retrograde wire to advance into the guide extension. So you did it really quickly. You did it very elegantly. I think at this point now with retrograde wire externalization, you have a good rail and you can do whatever you need to set up for the rest of the sort of more conventional PCI. Tell us, when the microcatheter jumped across that other part, did you do a test or anything? Were you concerned that, because sometimes with an epicardial, when the microcatheter makes progress, it goes where you want it to go, and sometimes it's also a perforation. So anything that you were concerned about there, or anything you did specially?
I was a little bit concerned, so we made a check. We made an angio check. There was no perforation, nothing. So yeah, in that we went on. We saw that the pressure was excellent. So we are not scared at this point. Of course, when we are going to remove the microcatheter, we will always leave the wire in to have a check first, to see if there is any perf, and in that case, we can have a rapid access to the epicardial. So this is very important whenever you do retrograde, but especially for epicardial, when you remove the microcatheter, at the end of the procedure, leave the wire in and make a check. That is a very important step for safety.
So you can go ahead and keep working. I think the reason I made that point is because somebody as good as Roberto, he does probably 100 different steps like this during the course of the case, and you need to be able to recognize what those steps are, because if you omit them and something bad happens, that's when you get into trouble.
Roberto, it'll be interesting to see if you do IVUS, whether you actually were subintimal or whether you went.
We already have we already have the IVUS on the table, so we are ready to do IVUS. We are going to do externalization, and then we will do IVUS on the RG3 wire to try to understand exactly what kind of lesion we have. I expect a very calcified lesion because we saw what the balloon was doing.
Perfect. So why don't you guys show us what you're going to do? We're going to stop talking and you tell us what you're going to do, because we're coming up on some limited time too.
Sure. So now we are going to externalize. So basically we are using a very long wire to externalize. That is the RG3. It's already there, I guess. You can see the externalization maybe?
His hands, not the angio screen. That would be great.
So you can see here the externalization of the wire. So it's coming from the left system up to the epicardial in the right system, and now we have here the externalization of the wire. You see them?
And then he'll load that on the wire introducer, which allows it to then come out through the Y adapter.
Sure.
Now, one of the reasons it's not bleeding so much is because he has the guide extension down into the right via the antegrade guide. Other times when you don't have a guide extension, you can sometimes put a Kelly clamp up more on the guide so that it doesn't bleed as much during this time period. But now you'll see the wire come out through the Y adapter, and then he has a nice rail to be able to do all the work he needs.
So you see the wire coming out. Now it's there. See that?
Yeah, we see it very well. That's great.
Yeah.
Okay, so we will go doing PCI on this wire, and IVUS first, of course. I also like to check this, as it is an epicardial. You can feel sometimes the heart moving on your wire when you do externalization. So I like to have, in this specific case, to have some fluoro there, just to check that there is no prolapse of the guiding. One time we saw a prolapse of the guiding in the epicardial, was not nice.
The other thing that's important is if you know the orientation of the epicardial when you cross, to now, it's important to just get in your mind's eye what that difference is, because sometimes the wire can cheese grate across the epicardial and you won't recognize that until later, and then that's because of a big perf. So just knowing what it looked like and making sure that doesn't change, especially as you're advancing into drawing equipment.
Sure. So now we have to also to come back a bit with the microcatheter. So I usually do clockwise, sorry, for the Corsair. In this case, I will do anti-clockwise, so the reverse of what I did to push it forward. So now we are distal enough, I guess, and we can do the IVUS. Shall we get the IVUS?
And it's obviously important when you do that to watch your donor guide catheter doesn't get sucked into the donor system.
And then
yes,
he also leaves
you have to disengage
the distal right. He leaves it in the distal right so as to avoid, again, the microcatheter is now protecting the collateral. So he'll leave it there till pretty much the end, and then go from there. But he disengaged the guide first, I think, and then did it.
Yes, the guide is a little bit still engaged. One thing that you need to do when you push back the microcatheter is disengage the guiding on the left. That is also extremely.
So we lost sound for a little bit, but what I think he's going to do is he'll go ahead and IVUS and see if we can't see the IVUS images because it looks like the image is frozen as well. What we could probably do is jump back to the other site and then come back as we see the IVUS. Okay, it sounds like they'll be back in just a second, so we'll keep going. Yeah, Didier, go ahead.
One comment.
Sorry.
Yeah, I wanted to say that one of the main learnings for me from this case that is perfectly well executed is the value of the guide extension, as you mentioned, Margaret. And this can really improve your ability to cross retrograde directly with the wire and to make everything, your life easier after the crossing. Because sometimes when it comes to catch the wire with snares, it may be a little bit more lengthy. So it's good to get that extension down and to be able to wire it directly.
You know, it really can help facilitate things. So here's the IVUS images. We still don't have audio from them, but it looks like it's still in the guide extension. So we'll see what.
So here it looks like there is a negative remodeling, and it looks like a very small lumen. Yeah. What do you think?
Yeah.
It does. Either that or it's still in the, where I can't see the angio image, so I can't tell where it is.
It's in the mid. Yes. So here is the position.
Okay. Oh, so you wanted to
Bert, was that the high definition IVUS?
Yeah, it's the high definition IVUS. I like it a lot for this kind of procedure. It's amazing because you can really see also the flaps, and in this case, it's really nice. It's a good compromise between IVUS and OCT.
Yeah. Just have to flush the catheter pretty well to start, but here you see the lesion itself.
Bigger vessel, yeah.
It's all luminal. It's in the vessel. It's not. I don't see anything. There's your calcium. There's dissection for a little bit, but that's okay. We had this big balloon, but it looks to me like this is all true lumen and not really subintimal space.
Yeah.
Yeah, it's true. Looks like.
Yeah.
Which
we like it.
There's a
subintimal space down there.
Yeah, there was a little flap at 6, 4 to 6 before, but now against the. You know, sometimes you like it, sometimes you don't. If it's super calcified, sometimes the true lumen is not great because then you have to do atherectomy. But in this case, it's not circumferential, and it yielded after the initial balloon. So this should be able to expand with conventional balloons and then stent.
We are at almost at the ostium.
A lot of positive remodeling here. Big
Yeah, true.
Yeah. Proximally, yes. In the mid-distal portion, I saw some negative remodeling, actually.
Yeah.
That was one of those branches, and now here it gets big to the osteum.
Yes,
all right, great.
So
just because I have to go back to Leipzig, so just tell us really quick what is your ballooning and stenting strategy, and an amazing demonstration, by the way, to get that epicardial.
Yes, thanks a lot. So we will go for predilatation, of course, in the proximal part. I think I haven't seen exactly what the diameter is proximally, but I think it will be around 3.5 stent at the proximal part. And I need to check if we are coming from the epicardial to a side branch. So probably what we saw distally, this small vessel, could be that we are entering in the right from a side branch, not really from the main branch. So I want to double check this, and then we will go for stenting in the proximal mid portion.
That's a very important point, though, because if you're through an RV marginal or something and you end up just stenting indiscriminately, especially the way that IVUS looked like, then you're going to shut the door on the main branch. So it may be something where with a dual lumen catheter, you're able to find the main vessel and go that way. We're going to leave you and go back to Leipzig. This was a fantastic discussion. Thank you so much for the demonstration, I mean. It
was a pleasure.
Good luck with the patient. Thanks again, okay?
Thank you.
Good job.
My goodness. Yes, Ross.
Yeah, so
all right.
So we tried. Let us show you what we tried.
So we tried the parallel technique with the pilot 150. But this failed as well. Therefore, we decided to go for a retrograde approach.
Which makes sense. And I don't think there was anything wrong with trying that way, especially with a relatively safe wire.
Yeah, exactly. So we tried not to be aggressive.
With the parallel wire technique,
but we stopped at this point, and now we went retrograde.
So
maybe we can show the septal collateral.
Yeah, show us the septals, and maybe Didier, Margaret, or Azeem, how do you get into the septals, or what's your standard approach, wire-wise?
Yeah. So as I said at the beginning, we have a 6 French approach. It's an EBU 3.5, and this is it's a workhorse wire, a BMVW, to get access to the septal collateral. And we have a Corsair Pro microcatheter.
So typically, workhorse wire with a relatively big bend finds your way in, then advance the microcatheter, and then wire out, reshape for a dedicated septal sort of wire at that point.
So there are actually 2 septals just before and just after this old stent. And our main target would be first the second septal collateral immediately after the stent, which I think is this one.
Yeah, this is this one.
Yeah.
So now I try to...
We will probably start to struggle a bit with the 6 French, as you anticipated.
Yes.
Let's see how this behaves.
Okay, no.
We need a longer
So
guide.
we have no backup, or not enough backup with our EBU 3.5.
And do you think the stent's causing you a problem there, getting into the septal?
Yeah, maybe a little
Maybe,
bit.
yeah.
There's a host of issues, but yeah. Yeah, the other thing with the BMW is because it has that shaping ribbon and it tends to prolapse, it's sometimes you have to get it in a little bit further, but this time you've gotten it in, so.
So
This is another
now we
example where a
change
guide
for
extension may be helpful
Xeon Black.
at this point. So really, really tiny bend because the septals are going to be small.
Yeah.
And then we'll see surfing.
Oops.
And Ajay, what's your first?
So I know
septal?
Nicolas wanted to see
What do
surfing.
you use?
Sorry?
And then I was saying, Nicolas, you wanted to see surfing, but in the last case, they went epicardial, so now we get to see our surfing. So we're good.
Yeah.
Yeah.
Margaret, what were you saying about the wire?
So it's this is Xeon Black.
Xeon Black.
Yeah.
So Mohammed, can you give us some insight? What is your first choice for septal surfing? Which wire you first use to
I'm now
use
trying to
septal
find the
surfing?
right way. Push it, drill it. Maybe we should do another NGO. Or can you show the NGO again with the septal?
Yeah, the angle is not that perfect, so probably we need to
Yeah.
to repeat it.
Yes, Nico or Mohammed, can you tell us which wire you use first for septal surfing?
Yeah, so I mean there are a lot of wires, of course, over there. So we prefer the Xeon Black, the one we're using here. There are a lot of other options, like the XTR, for example. So the wire that has been used now for the epicardial apparatus, the ZOO wire, we don't usually use it for the septal collaterals, although it may be helpful if they're extremely tortuous. But at least for the beginning, we would start with the Xeon Black or appeal the XTR.
So this is a good example of you see robust collaterals, but down by the lower in the septum, they become very, very tortuous. So sometimes these can be maddening. Margaret, is there any one in particular you think would be best to surf in this case?
Yeah, so they're obviously in a branch that looks like it's got 3 distal forks. The first one looks bigger, but looks quite tortuous.
Yeah.
And the one that they're in looks like it goes slightly more apical and then back round. I think I would explore the one that I was in here and see if that flips back. And if it didn't, I'd come back and go, yeah, there you go, into the bigger one. But there is quite a lot of tortuosity in that larger branch. But a lot of it is just about feel.
There's also a really apical looking septal further down the LAD that could be explored later too. But sometimes this is just trial and error, and you have to sort of see.
So
that's
Ajay,
too high.
Let's see where we are.
It seems high, but maybe with an angio you'll see.
Yeah, it's too high.
It's too high.
Very occasionally you get little branches like that that go to the RPLV.
So Ajay,
am I a little bit old-fashioned, or is there anybody who starts with the regular cyan wire?
I do the deed.
Okay. So this is a question to the panel. At what point in time would you decide to switch gears and to say, listen, now we have to, this case is taking a twist. We have a 6 French guiding in the left coronary. Why not just upgrade and then proceed, rather than now attempt with a 6 French guiding?
Totally right. Yeah. Totally right.
You're totally right. Yeah.
Generally speaking,
I think we should
whenever
do this,
you're thinking that to yourself in the case, it's that time had passed like 30 minutes ago. So earlier the better, typically.
Yeah.
Yeah.
Because the problem here is that if you get round with the wire, you're then going to have a little support for the microcatheter. And then once you get through the distal cap, you're going to have a little support for the microcatheter, and you're going to struggle the whole way and make life difficult for yourself. But I know how it is. Sometimes you're committed and you don't want to go backwards.
7 French Länderschleuse bitte und ein Evo 4, 7 French.
Yeah.
No, so actually, so they're telling us we're actually running out of time on this. So I think that, look, you've gone through methodically, you know, how you do this, antegrade, then parallel wire, now going retrograde. I think you're going to get the right setup. There are abundant septals. It may not be the first one that you find, but you'll get it, and then you'll be able to deal with that bifurcation in a much more controlled way by going retrograde. So we're unfortunately going to have to leave you, but it's been actually a great demonstration. The one thing I was thinking to myself, that's the only problem with the internet format, we can see you great, but you can't get any clapping. So apologize with that. That's obviously a nice positive reinforcement for the effort you made, but we can't give it to you. So sorry about that. But thanks again to you and your team.